Welcome to the Prevention Subcommittee. For the Attorney General's Working Group on Substance Use, I am your chair, Jessica, calling in from Washington, D.C. today. I made it, so hooray for travel. We are going to get started here in just a moment, letting a few folks join. I appreciate you all being here, and we have some great presentations for you today. All right, let's go ahead and get started today. We'll go to agenda item number 1. This is the call to order and roll call to establish quorum. Before I turn it over to Mary to establish quorum, we do have a new update from our DAG that I wanted to just include here. If a member needs to depart the meeting prior to adjournment for any reason, they're asking that you formally announce your departure for the record to ensure accurate minutes and to allow myself to confirm that the quorum remains in accordance with the Nevada's open meeting law. So thank you in advance if you need to leave early for any reason, for just letting us know so we can note that for the record. With that, I'm going to turn it over to Mary to establish roll call. Mary?
Thank you, Chair Johnson. So as I call your name, please just indicate if you are present. Jessica Johnson?
Present.
Wendy Nelson?
Present.
Chelsea Cheatham?
Present.
Noelle Cheney? Stacy Lance?
Present.
Kyra Morgan?
I'm here.
And Rosa O'Bannon?
Present.
Great. Chair Johnson, it looks like we have a quorum. I also wanted to just make a note that we do have a new member of the SURG that has just elected to join prevention. That is Senator Neal. And while she has elected to join us, it was done very recently, so she's not able to come today, but she'll be joining starting probably in the May subcommittee meeting.
Fantastic. Thank you, Mary, and thank you all for being here today. I really appreciate it. With that, let's move on to agenda item number 2, which is our period of public comment. I'm going to turn it over to Mary to make sure that we are in compliance related to public comment. Mary?
Thank you, Chair Johnson. Mary O'Leary for the record. Public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and any discussion of those comments. No action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken per NRS 241-021. If you are dialing in from a telephone, please dial 253-205-0468. When prompted, enter the meeting ID 813-0733-6896, and then please press *6 so that the host can prompt you to unmute. We also ask that members of the public are requested to refrain from commenting outside the designated public comment periods unless specifically called upon by the chair.
Thank you, Mary. Do we have anybody for public comment?
Doesn't appear to have anyone. I would just note for the group as well, we did put it in the chat, but we do ask that folks also not use the chat for anything other than technical assistance requests. That's because that becomes part of the public record and it may not be available to people who are calling in. So things you put in the chat are not visible to people who are just calling in by phone. And so that can cause issues with making sure everyone has the same information. So again, please refrain from using the chat unless you have a technical assistance request.
Thank you, Kim. Don't see any hands raised for public comment, so we will go ahead and move to our next agenda item, With the agenda item 3, review and approve our November 5th, 2025 Prevention Subcommittee meeting minutes. It's been a minute since we've had the opportunity to meet together. I'm really glad to have you all here today. And I'm hopeful that that extended period of time gave you an ample opportunity to review the minutes. So do I have any discussion for the minutes today? If not, I'd entertain a motion to approve the November 5th minutes.
Jessica, this is Kyra. I'll move to approve.
Thank you, Member Morgan. Do I have a second?
Rosa O'Bannon, I second.
Thank you. All in favor say aye.
Aye.
Aye. Aye.
Any opposition? And any abstentions?
I believe I am going to need to abstain because I was not on the committee at that time.
Thank you. So 1 abstention for the record. Thank you, Chelsea. I believe that motion carries. Is that correct, Mary?
I believe that was still 5 members, so yes.
Perfect. Okay. Thank you, everyone. We'll move to agenda item number 4, which is a 2026 timeline reorientation and review of the recommended submission process. So we changed things up this year in SURG land, and so wanting to make sure that everyone is clear on our next steps and how this will be, what our report cycle will look like. So for our subcommittee, our meetings, this is what our meetings look like for the rest of 2026 and 2027 to ensure that we have the opportunity to see these reflected correctly in your calendars. Noting that our June 17th meeting will be our last subcommittee meeting before our 2025-2026 SURG report is complete. So I wanted to just make sure that this made sense to everyone. Mary, I'm going to turn it over to you. I think you have some more details on this front. Thank you.
Yes, thank you, Chair Johnson. Mary Leary for the record. So I'm just going to walk us through how our subcommittee meetings and full SURG meetings will sort of fit together for the rest of this year. So I'll be toggling between 2 different sides, so please try to follow me. It does get a little confusing with all the dates and times going on. So back in January, we met to approve the final progress report. Then we had our February meeting planned. It did not happen, but we intended to focus on the preliminary recommendations. And that brings us to today when we will be focusing on said preliminary recommendations. We'll also hear from some subject matter experts as requested today. So then moving forward, what will happen is we will take our preliminary recommendations from today that we decide to move forward with, and we'll go to the April full SURG, and there'll be some presentations from some subject matter experts on peer certification, the state budget process, and an update for the Fund for Resilient Nevada. And then the full SURG will also weigh in on said preliminary recommendations from all the subcommittees, so you'll also get a chance to weigh in on what the other subcommittees are up to. So then following that, we'll meet again as a subcommittee in May to sort of take that feedback that we were given in April, see if we want to make any adjustments, then we'll finalize and rank our preliminary recommendations to then present back again at the full SURG in June. So it's more of like a cycle. It's a very reiterative. We also may have some subject matter experts present in May as well. We will also be approving our annual report template in June at the full SURG. So then we also right now have, as Jessica mentioned, we have a June subcommittee meeting booked. That is more of an if needed effort. We may have some feedback from the full SURG in June that we want to take back and discuss. We may be feeling okay with our recommendations as they are. We'll just see how that plays out as it gets closer. So then once we come together again as the full SURG in July, we will have our full slate of recommendations. contained in the annual report, which we will then approve. So that is our current reporting cycle. Then we'll move into the fall, which is our next reporting cycle. So we'll start having presentations from subject matter experts in our subcommittee meetings. We'll start to develop new recommendations, maybe maintain some old ones. And we'll also have a full SURG meeting in October where we sort of get reoriented. We hear some presentations as well, and we'll keep moving forward. So it's really, we develop in the subcommittees, we take it to the full SURG who reviews, we'll refine it in the subcommittees, and then we'll finalize and approve in the full SURG. So it's sort of a, keeps moving. And as we move through this, please feel free to email myself or any SCI team member if you have any speaker and subject matter expert recommendations for presentations. We definitely want to make sure we get inside or outside input from anyone that you think is needed to really strengthen any recommendations that we do have. Speaking of recommendations, we just wanted to quickly go through the recommendations process. So recommendations, they can be submitted by members using the survey link that we've sent out, and I can also send out after this meeting as well. We just ask that you please complete each section of the survey to the best of your ability, and be prepared to present the recommendation to your members at the next regularly scheduled subcommittee meeting. And then to support your development of the recommendation, we at SCI can really assist you with gathering any information you might need help with gathering and connecting with subject matter experts as well for those presentations. And then we just wanted to note that any information that you provide in that survey is often included in the final annual report to really kind of bolster the justification and all the background information for those recommendations.
Thank you so much, Mary. Any questions from any of the subcommittee members for Mary about this process? For those of you who are new, it's probably just understanding the process from any SURG folks who've been around for a minute. It's a little bit of an adjustment. So just wanting to make sure we have some opportunity for clarity, and looking forward to hearing, as you all are subject matter experts across the state. Really important to me as your chair and to the SURG that we really benefit from any observations or opportunities to hear recommendations to fill gaps and improve processes. So if you have any ideas that you would like to be incorporated into this year's report, it's pretty important that we get them submitted before May so that we can make sure they're in this year's annual report. Totally okay to submit something any other time. It may or may not, we may or may not have the opportunity to discuss and vote on it this year. So then it would just be in the subsequent year's annual report or at a different juncture. So, yeah, so we'll be including, for example, I think there are 3 recommendations so far. We'll discuss them later in this call, and then we'll work on finalizing those. So. Any questions from anyone on this agenda item? All right. Yeah, it's a clear process. Thank you so much, Mary, for orienting us. Let's move on to agenda item number 5. So today we're going to hear from the tobacco and cannabis prevention funding landscape and some recommendations. I'm really excited to have Lisa and Malcolm here to talk to you a little bit more about their work across the state of Nevada and some of the recommendations that the SURG subcommittee has entertained as part of our work. So Lisa and Malcolm, I'm sure you both please give yourselves more of an introduction than that, and glad to have you. The floor is yours.
Awesome. Thank you, Chair Johnson. Before we get started, I also want to give a big thanks to Kim and Mary from the SEI team. They have been fantastic and I would say patient with me as finally getting us on this schedule. There was some health battles that I was going through that delayed us coming here to finally make this presentation. So thank you so much for the opportunity and the time today. I want to introduce myself, then I'm going to kick it over to Lisa. My name is Malcolm Alo. I coordinate our tobacco control program at the Southern Nevada Health District. But I'm here in the capacity of the Nevada Tobacco Control and Smoke-Free Coalition. I've served as president for the last 3 terms, but I termed out and I'm no longer president, but I had experience doing this SURG process in the past. So that's why I'm here, but I want to kick it off to Lisa because she's our current president and give Lisa a chance to introduce herself. So go ahead, Lisa.
Great. Thank you, Malcolm. And thank you for having us here today to talk about tobacco and cannabis. My name is Lisa Sharetz. I'm a health educator specializing in youth vaping prevention at Northern Nevada Public Health. And as Malcolm said, I'm currently serving as the president of the Nevada Tobacco Control and Smoke-Free Coalition. Next slide, please. Just wanted to make clear that we have no disclosures. Next slide, please. So as I look at the members of the committee, I'm sure that you're familiar with this, that we are in a youth vaping epidemic. 1 in 3 teens have tried electronic vapor products. This is important because we know that tobacco use is the #1 cause of preventable illness and death in the United States. And what we're finding is that a lot of times youth who vape will then go to combustible tobacco when they're not able to vape. So there's risks to both types of products. And tobacco kills so many people annually. We used to say 4 jumbo jets crashing. And so daily. So this is a continuing problem. And, there was supposed to be a tobacco-free generation, but that date has passed. And we want to ensure that our children's children don't have to deal with this issue as we are. And then prevention is the key. 90% of adult smokers start before the age of 18 because of the way nicotine affects the brain before the brain is fully developed. Next slide, please. So we have some stats here. The prevalence rate, current ever tried vaping for high schoolers, 33.6%. And these are from the 2023 Youth Risk Behavioral Survey. For middle schoolers, the current ever tried rate, so curiosity, it's natural to that age, 17.6%. Current past users in high school, that is known as the chronic use. They used 30 of the past 20 days, and that's 15%. And in middle school, same thing, 20 of the past 30 days, 8.4%. And then you can see from 2019 to 2021, the percentage of Nevada high school students who vaped, whoever used, dropped. And reading right to left, the percentage of Nevada high school students who vaped in the last 30 days decreased. And then the next row, the percentage of Nevada middle school students who ever used vapes decreased from 2019 to 2021. However, the percentage of middle school students who vaped in the last 30 days increased. Next slide, please. I'll turn it over to Malcolm.
So I'm going to talk about marijuana or cannabis, and just to give a 101 on what this is. So cannabis, just for people who are not so familiar, is the plant name or the scientific name of the plant or the genus. And then there's 2 types of things that come off of cannabis, which is marijuana and hemp. So hemp has low THC and marijuana has high THC. So when I'm using the term hemp, cannabis, or marijuana during my presentation, it's all referencing the same thing. So when I say marijuana is addictive, 1 in 6 teens start using marijuana, and 20 to 25% of people who use marijuana as a teen use it every day, and they're becoming addicted to it. Teenage marijuana is at the highest level in the last 30 years, but this is a nationwide fact. In my next slide, I'm going to talk about how Nevada is actually doing better than that, and we're actually seeing a decrease in marijuana and cannabis use. So teenage marijuana use is the highest nationwide. And then we all know that the teen brain is actively developing and continues to develop into the age of about 25. So it's important that we get teens not using cannabis products before the age of 25 because it can have some harmful effects. And then this fact hits home for me a lot because I work with a lot of teens in the high schools, and I see this quite often, is that teens who do not use cannabis compared to teens who do use cannabis either quit high school or do not go to college or do not have a college degree. Next slide, please. Like Lisa covered, the YRBS prevalence for use in Nevada, current tried for high schoolers is 28.7%. So that's how much, almost 1 in 3 teens have tried cannabis in high school. For middle school, that number is at 11%. Chronic use or current everyday use for the past 30 days in high school is at 13.7%, so almost 14%. And then for that same number for middle school is at 6%. So you can see we're doing much better than the national average. But here's where it gets alarming on this bottom half, is that among high school students in Nevada in the past 30 days, the methods of use has shifted. We see smoking marijuana or smoking cannabis the traditional joint way has decreased from 59% down to about 41%. Dabbing cannabis went from 15% to 8%. But when students report on the YRBS how they use it using vaporizing it, that has seen a drastic increase from 18% to 31.6%. So the way they're using cannabis is using vape products. And that's why we kind of marry the two with cannabis and tobacco control, because we see such overlap with the two products. Next slide, Mary, please. Go ahead, Lisa.
So we're here today with some recommendations. The youth vaping prevention funding that I believe it was two legislatures ago has been eliminated. And so we look to other resources. Nevada tobacco revenue, there's $214 million revenue generated by cigarette taxes, other tobacco taxes, and master settlement funding. So there's 130.95 or 130,945 million of cigarette taxes that the state garners. Zero is put forth for tobacco prevention. 932 million of other tobacco taxes, zero goes to prevention. And then the 14.6 million of the Juul settlement, that is, and zero goes for tobacco prevention. And then 36.5 million from the master settlement funding, $1,101,954 goes for tobacco prevention in 2024. So this equals 0.5% allocated in all those revenues in Nevada to tobacco control and prevention efforts. Next slide, please. Next slide, please. Oh, sorry. I jumped back, sorry. Youth vaping prevention funding, yeah. So Nevada tobacco revenue, as we said, 231 plus million from cigarette taxes, other tobacco product taxes, and settlement funding. CDC recommendation for Nevada tobacco control and prevention is 30 million. And then I'll finish this slide, and I see a hand up. And then Nevada currently, the CDC recommendation for Nevada tobacco control and prevention funding is 30 million. Nevada currently contributes over $1 million for tobacco prevention in 2024. And this ranks Nevada as 46th in the country for tobacco control and prevention funding. Chairman Johnson, I don't know if, yes, go ahead, Malcolm.
Lisa, if you don't mind me, Chair Johnson, if you don't mind me interrupting real quick, this was a typo. It should be 214 million instead of 231. So Mary, if you don't mind making that change, if possible, it should match the front slide on page 7. So it should be 214 million from cigarette taxes, other tobacco taxes, and settlement funding is the correct total. But sorry, Chair Johnson, that's why I just wanted to make that correction.
No, thank you so much. I really appreciate the presenters. Noelle, if you're okay, we're going to just hold questions until the end.
Sorry, Chair Johnson. believe Noelle is just joining, so
Oh.
she might be stating for the record that she has arrived.
Yes, that is correct. Thank you so much, Chair Johnson and Mary. I just wanted to share for the record, Noelle Shanae, I did join about 2:50 p.m., so wanted to let my presence be known. Thank you so much, and my apologies for my tardiness.
Welcome, Ms. Shanae. Thanks for hopping on. Back to you, Malcolm and Lisa. Thank you.
Yeah. Welcome to the party. Okay, next slide, Mary. Thank you. So Lisa covered the tobacco landscaping, and here we're going to talk about cannabis and marijuana landscape here with tobacco tax. So when you come, there's two types of marijuana tax. There's a retail marijuana tax or cannabis tax, and then there's a wholesale cannabis tax. When you combine them two, it brings in the state about $118 million total. And when you separate them, and we're going to talk about what separating them means and where it goes in our state, 37 million comes from the wholesale cannabis tax, and about 75% comes in from the retail cannabis tax. But like how Lisa was mentioning, zero goes to prevention, zero goes to prevention, zero goes to prevention. We have the same situation here where $0 of the tax that's collected, whether it's wholesale or retail, comes to the local lead agencies or the local health districts for cannabis use prevention. So we just want to make that super clear that of the 118 million, 0 comes to prevention. Next slide, Mary. Thank you. This was a slide that we needed to include, but we're just asking for prevention funding to address youth and priority populations that use these products at higher levels, according to the YRBS, African Americans, Hispanics, Latinxes, LGBTQ+, low income, and SCS communities. And then the sub-priority populations, when we're doing in-person interviews in these high schools, we're finding that those that are into sports or athletic or student athletes are the ones that are using vape products and cannabis products at higher levels compared to their counterparts. So the big population is youth, the subpopulation would be athletic youth if we can get that specific. Next slide, please, Mary. Thank you. Go ahead, Lisa.
Great, thanks, Malcolm. And as Malcolm was saying, tobacco affects those the most who can afford it the least. What's working well is evidence-based practice. A comprehensive tobacco control program is statewide. It's a coordinated and sustained effort to establish smoke-free policies and social norms to prevent tobacco use initiation and to promote quitting and help tobacco users quit. And that's one of the things the Nevada Tobacco Control and Smoke-Free Coalition does is bind together tobacco partners across the state. So goal one is to prevent tobacco use. You know, once the horse is out of the barn, it's much more expensive to get the horse back in the barn. So prevention saves money. So preventing tobacco use initiation and among youth and young adults. And goal two, promote quitting among adults and youth. And then goal three is to eliminate exposure to secondhand smoke. As everyone knows, there's no safe level of exposure to secondhand smoke. So CDC best practices state that a comprehensive tobacco control and prevention program would include state and community interventions, mass reach, health communications, cessation interventions, and surveillance and an evaluation. These strategies help reduce tobacco-related disease, disability, and death. And that's from the CDC Tobacco Control Program best practices. Next slide, please. So where there are gaps, as we've mentioned, youth tobacco vaping prevention funding is not funded in the state of Nevada. There's lack of resources throughout the state, including cessation resources for youth and adults. And federal tobacco prevention funding is not reliable at this moment. Next slide, please. So some more gaps. The American Lung Association's 2024 State of Tobacco Control Report, funding for state tobacco prevention programs, we got an F. Nevada got an F. As we mentioned, it's 46th in tobacco funding. Strength of smoke-free workplace laws, a C. Over 70,000 Nevadans are exposed on a daily basis at where they work to secondhand smoke. Level of state tobacco taxes, F. Coverage and access to services to quit tobacco, F. Minimum age of sale for tobacco products to 21, F. And a campaign for tobacco-free kids, 2024 state ranking report. Nevada is ranked number 46, tied with Alabama. Tennessee, Texas, Georgia, West Virginia, all are lower than we are. And then Nevada funds 3.6% of the CDC recommended 30 million. Next slide, please. So our recommendations. Our first recommendation would be to allocate and prioritize tobacco control and prevention funding with tobacco settlement funds, that would be the master settlement dollars, or tobacco tax dollars. The Nevada Tobacco Control and Smoke-Free Coalition recommends dedicated tobacco control and prevention program funding. We recommend funding at a minimum of $2 per capita, or $6.4 million. That would be per year. The CDC recommends 30 million. So if Nevada did fund $2 per capita, that's 6.4 million, that would move Nevada from 46th in near the bottom of tobacco funding up to 24. And perhaps more meaningful than that is the lives it would save, and the healthcare costs it would save. So our recommendation is to create a bill draft request to amend the NRS for a 17% set aside of tobacco control and prevention funds from the Fund for a Healthy Nevada. As you all may remember, the Fund for a Healthy Nevada is funded by the master settlement dollars. And that would be Chapter 439, Sections 620 to 630. And then allocate funding to local communities using the local lead agencies model. Southern Nevada Health District, Northern Nevada Public Health, Central Nevada Health District, Carson City Health and Human Services, the rural coalitions. We are poised, ready to tackle tobacco, but we need funding. Next slide, please. More tobacco recommendations is to allocate and prioritize tobacco control and prevention funding with tobacco. Oops, is this the same slide? Looks like it. Oh, no, it's not. Sorry. But I'm repeating myself. Yes, it is to prioritize tobacco control and prevention funding with tobacco settlement or tobacco tax dollars. You saw the millions that tobacco taxes bring in. Create a bill draft request to amend the NRS to allow for tobacco, nicotine, vaping settlement dollars, which come from the Juul settlement, to be allocated for youth tobacco control and prevention efforts. Currently, Nevada receives $14.6 million from the Juul settlement. Currently, tobacco prevention receives $0. And from the states that sued Juul and successfully won, Nevada's intent in the settlement is, quoting, "It is the party's intent that the payments may be used to fund consumer protection programs and services, including but not limited to programs or services created by the Nevada Division of Public and Behavioral Health to address, mitigate, educate, or prevent youth vaping in the state of Nevada," end quote. And then another recommendation, as we've recommended before, is to allocate funding to local communities using the local lead agencies model, which would be Southern Nevada Health District, Northern Nevada Public Health, Central Nevada Health District, Carson City Health and Human Services, and the rural coalitions. Next slide, please. And then I believe this is the last slide of our tobacco recommendations. Recommendation would be to allocate and prioritize tobacco control and prevention funding with tobacco settlement or tobacco tax dollars. We're repeating ourselves. Use tobacco pricing strategies, such as increasing the price of tobacco products to decrease youth prevalence. Allocate funding to local communities using the local lead agencies model, which is Southern Nevada, Northern Nevada, Central Nevada, Carson City Health and Human Services, and the rural coalitions. Next slide, please. And I'll turn it over to Malcolm.
Thank you, Lisa. And just to be clear, for the subcommittee here is that the goal is $6.4 million for tobacco control and prevention, and we outlined 3 different strategies on how we can get that number. To summarize real quick, it was 1, increase the price of tobacco products; 2, amend the current NRS to reallocate the master settlement agreement funds to 17%. And then the third one is any settlement funding as a result from tobacco litigation comes to tobacco control and prevention. So either one of those ways will get us to the 6.4 million. A combination of those ways will get us to the 6.4 million. Of course, we're not saying pick 1 or pick 2 or pick 3. Of course, we want all 3. But if we had to, our goal is the 6.4 million for tobacco control prevention using one of those 3 strategies that are all options and available here in Nevada to get that number. Moving on to marijuana, to cannabis, the same recommendation we hold with tobacco control. We had $2 per capita, equaling $6.4 million in our state for youth cannabis prevention. We want to create a bill draft request to set aside $6.4 million from the cannabis control and prevention funds, from the wholesale tax and the retail tax. And the next slide I'm going to go in is going to make more sense. So we can go to the next slide, please. Thank you. So how cannabis is taxed here in Nevada? 2 ways. There's the retail tax and then there's the wholesale tax. The retail tax is 10% of the excise tax, and 100% of that 10% goes to the state education fund. So that's what the voters approved, and all the money goes to the education, and that is happening, and that is true. So 100% of the retail tax from cannabis goes to the state education fund. Then the second type of tax for cannabis is the wholesale tax, and that's 15% of the wholesale. Only parts of this will go back to the state education fund. So what happens first with the 15% is the Cannabis Compliance Board, or the CCB, would take any administrative or enforcement costs right off the top of the wholesale tax. Then it goes to local governments, and local governments would take what they need to enforce the cannabis control here. And then any remaining funds, which is a lot of funds, gets reverted back up to the state education fund. So the state education fund gets funded 2 ways: 100% of the retail tax, and whatever is left over from the wholesale tax after CCB and local governments take their piece. We're asking that before the money gets reverted back up to the state education fund, the wholesale tax gets, Cannabis Compliance Board takes their first chunk, local governments take their second chunk, and 6.4 million gets carved out for cannabis use prevention and control before the remaining balance gets shot back up to the state education fund. I know that's kind of confusing, but that's the best way I could explain that. And once the funding is available, using the same method that Lisa pointed out, allocate this using the local lead agency models, which would be the Southern Nevada Health District, Northern Nevada Public Health, Central Nevada Health District, Carson City Health and Human Services, and the Rural Coalition. Next slide, Mary. Oh, and then here are our references. You can click those if you are interested in more information. And the next slide, please. Oh, and then our contact information. So Chair Johnson and subcommittee, before we open up the floor for questions, I just also wanted to thank you all for using and acknowledging the tobacco control recommendations from the last cycle and including that in one of your final recommendations. Greatly appreciate it. And hopefully the same goes this round. So that concludes our presentation. Chair Johnson.
Thank you both so much for a really wonderful and clearly well explained presentation. You're both very knowledgeable on this topic, and glad to have you here. Fellow subcommittee members, do you have any questions for Malcolm or Lisa about the information that you've heard today? Yeah, Noelle, go ahead.
Thank you so much, Chair Noelle Cheney, for the record. And I just was curious as to whether or not you could give a little bit more insight into that F grade for the Tobacco 21 initiative. I know in Nevada you do have to be 21 to purchase tobacco. And so I'm just a little bit curious and wanting to learn more about that rating system, especially around that particular piece of our tobacco control program. If you have any information or light to shed, if I missed it earlier in the presentation, I apologize.
No, absolutely. Lisa, do you want me to take that or do you want to jump in? Me?
Go,
okay.
go right ahead, Malcolm. Thank you.
Thank you. Great question. So the reason why we get an F in Nevada for our Tobacco 21 laws is really twofold. One is because the sales rate to minors, those that are under 21, is quite high when you compare it to other states. So Nevada has a bad sales rate, meaning when you go to a convenience store or a place that sells tobacco products, youth is can easily access these tobacco products without even getting ID'd. So that's why we fail with the Tobacco 21 grade. The second thing is the tobacco retail landscaping, meaning we have a low tobacco licensing fee. It's only $50 a year per tobacco retail establishment, which is extremely low. Our inspections from the Attorney General's office to inspect our tobacco retailers happens only once every 3 years, when best practices is once annually to make sure that they're actually checking IDs and enforcing the Tobacco 21. So those are the two kind of components on how I would answer why we get an F grade is one, we sell too easily to minors. The access to tobacco products is there, easy to get. And then we can do better with our inspections when it comes to inspecting these tobacco retailers on an annual basis instead of what NRS requires now, which is once every 3 years. Hopefully that answers your question.
Yes, thank you very much.
No problem. Thank you.
Yeah, great question. Other questions from Prevention Subcommittee members? I have a couple, if that's okay, but I want to make sure.
Oh, Chair Johnson, please be kind.
Always. So, what I noticed in the presentation on marijuana, focused on combustibles and others. What can you tell us about edibles and how that plays into? Is that something you have stats on about what use is looking like among youth? Are there policies and regulations? What does that look like?
Yeah, so this one is a tricky question. Thank you, Chair Johnson, for the question. Is when you talk to school officials or school administrators, they say edibles is a big problem. They see the teens using edible products, and this is a problem for this reason. Those of you who are not familiar, when you take an edible, there's a delayed onset to the effect of the THC. So what happens is if teens take it at, say, 7 o'clock in the morning before they go to school, where they're not feeling the effects of the edible until 8 o'clock, 8 o'clock comes, they're not feeling it, 9 o'clock comes, well, guess what? They pop another edible, and then now they're getting a double dosage, and then they're having an episode by fourth period. And so the schools are treating that. That's the first issue. The second issue is schools are having a hard time enforcing or finding edibles because, edibles comes in all forms. They can be candies, gums, etc. So the enforcement of edibles is very difficult. When we look at YRBS data, the edibles, when teens are reporting edible use, it's very low compared to using it as a vaporized marijuana product. So if we're going by data, like through the YRBS, edibles might not be a problem we need to address just yet with no funding that we have available. But if we're going through observational data and interviews from people who are in the field and facing this issue, edibles is a problem.
Thank you for that very comprehensive answer. It seems like, sometimes we can't measure things, but understanding just sort of what the impact looks like. And I'm aware that like in other states that have retail cannabis, like Washington or Colorado, there's some pretty clear like state policy on like labeling and selling and those types of things for cannabis edibles. Are you aware of what that policy landscape looks like in Nevada?
Yeah, so when the CC, the Cannabis Compliance Boards, do their labeling and packaging and marketing, etc., we actually have a very good standard. Like Nevada is not behind it. We do very good things here in Nevada where we don't market to youth, and we have proper labeling and proper packaging, etc. So they do a great job. We have no recommendations on how that can be fixed. Obviously, would be zero marketing would be the answer to that question, but they're up there in the standards of responsible cannabis sellers, I guess, when it comes to that.
Thank you. Thank you for that answer. I'm glad to hear that on that front. So I really appreciate the thought that Malcolm, you and Lisa put into these recommendations and being really clear, I think, for our committee about, based on your experience, boots on the ground, kind of what has worked and where the other pieces are. Some of the pushback that I've heard, because we've had this recommendation around and some of the conversation has been around that other groups are currently like allocated to receive this, and you spoke to that a little bit. I was wondering if you could share a little bit more about that talking point. So in the master settlement, there are already kind of groups allocated for some of those funds. Same for the education fund. So if you could talk a little bit more about that piece.
Yeah, absolutely. So specifically, we're talking about the master settlement fund. So how this works is every year Nevada gets a deposit, and the deposit is determined on how many smokers Nevada has. And that number for last year was 36.5 million. Once that deposit gets into Nevada, it goes into something called the Fund for Healthy Nevada. The Fund for Healthy Nevada then divvies out that money to all sorts of social organizations or public health organizations that need different important services. Some are like for the hunger or the blind services, etc. So all worthwhile causes, and we understand that. Where we have concern is that the origination of this money is tobacco money, and the Master Settlement Agreement Fund's intent was to decrease smoking or decrease combustible cigarette use for youth, and that money is not being used as intended. So one, this goes back to those 3 recommendations, Chair Johnson, that we mentioned, is we don't want to take away this money from these organizations. However, we do have to recognize that tobacco control does need funding. So if we don't want to increase the NRS to increase the 17% from the MSA, which is the Master Settlement Agreement funds, the other 2 options is to raise the price of tobacco products using pricing strategies or tobacco tax strategies, and or any settlement funds like the dual settlement funds come for tobacco control. So there's multiple ways we can get to the 6.4 million. It doesn't all have to be in the MSA funding, but it's important to note that a lot of people think we're asking for MSA funding and we're going to hurt these other causes, but we have to remember where the MSA funds came from. And the intent of that was to decrease youth usage of combustible cigarettes. So we just wanted to be true to that.
Chair
Thank
Johnson?
you very much.
And Chair Johnson, if I
yes,
may.
Go ahead.
Thank you. If I may add on Malcolm's remarks, because tobacco is a product that people have to keep using whether they want to or not, the long-term effects and the health costs to Nevada are devastating, and a leak to our economy that can be prevented. So that's part of the cost of tobacco, let alone the human cost too. So thank you.
Thank you for adding that. Member Cheatham, I saw your hand up earlier. Did you have a question?
I did, but you had asked a really similar question to what I was going to ask. I was going to ask about a breakdown of where the funding is currently going, just so that we would know what could potentially lose some funding if these recommendations are put into place. Is there a list of who is currently receiving the funding from those sources that you mentioned?
Chair Johnson, answering that question is yes, we can provide you with this committee with that list on the current, or that list will change annually because people have to apply for that funding in like a grant form. So sometimes people will fall off and fall on, but we can provide you the 2024 list of current grantees, absolutely.
Thank you.
And Chair Johnson, I had one more. I never answered your question about the cannabis, about taking away from the state education fund. So right now, when we said that the retail cannabis tax 100% goes to the this slide 9, Mary, if you wanted to put that on the screen for people to see, 100% goes to the state education fund, the one right before this. That $74.5 million goes to the state education fund, no matter, and we don't want to touch that. That's 100%. We want to give that back to them. What we want to take is from the 37 million that goes automatically allocated to the Cannabis Compliance Board, the local government, then prevention, and then take the remainder and give it right back to the state education fund. So we do not want to decrease their retail allocation at 100%. We want to keep that the same.
Thank you. Member Shanae, go ahead with your question.
Yes, thank you very much, Chair. Another question, we're talking a lot about combustibles here. Is there any intent to utilize the requested funding increases toward addressing non-combustible tobacco products or nicotine products? I know it seems like we have seen a surge of pouches, to be specific, and advertising around them being more healthy and used to stay awake, used for industry, etc. Similar tactics, I believe, to what tobacco has done historically, and kind of wondering where that fits in to the proposed tax increases or funding increases, I should say.
Great question. I'll take a stab at it, then Lisa, you can take a stab right after me. Is absolutely, and this kind of falls in with the edible answer. Is that if we're looking at data right now at the current YRBS, there is less than 2% of people would self-report that they use nicotine pouches. Now, is that true? Is that what's really happening? Not sure. But sometimes, you know, in prevention, we are always a little bit behind the curve when we're following data trends. So yes, I do think that youth are using nicotine pouches at much higher levels. But this tobacco control and prevention funding would address combustible cigarettes, vaping prevention and education, as well as nicotine products. So all products that these teams are using, we would happily address. Lisa, do you have anything to add?
Thank you, Malcolm. Recently, Northern Nevada Public Health was working with the Gecko Club at Davidson Academy on the UNR campus. The Gecko Club is the environmental club of the Davidson Academy Public High School there. And they did an environmental assessment of UNR campus after we did a little bit of education about the toxic tobacco waste from vapes. And we expected that when they did the environmental assessment, they would find numerous vapes. And they didn't find that many vapes, but they found many, many, many nicotine pouches on the ground, under bushes, near Lake Manzanita shore, which, as you all know, nicotine is a toxic, hazardous waste. So with emerging products, as Malcolm said, we are running to catch up. But yes, anything that containing nicotine, and there are more things coming down the pike, we will address with tobacco funding. So thank you.
Yeah, fantastic questions and discussion. Thank you to our presenters. I don't know, Malcolm and Lisa, if you were able to stay on. I was hoping to have some subject matter expertise weigh in when we discuss our current recommendations, which may be at the next agenda item. We do have one on cannabis right now, but I was hoping to give the opportunity for committee members today to digest the presentation and maybe have you help us workshop a little bit the one recommendation that is on the table if you're available to stay on.
Certainly.
I'm happy to stay on. Yes, absolutely. Thank you.
Fantastic. Thank you both so much for a very comprehensive and detailed presentation. I really appreciate it and feel more informed about the work and the gaps from it. So thank you so much. All right, let's move on to agenda item number 6. This is our discuss and draft proposed 2025 prevention subcommittee recommendations. Oh, good. I had the correct agenda in front of me. All right. So the plan now is that we're going to go through some of the submitted recommendations. So committee members. So we'll talk through some of what's already available. I'm grateful to have Malcolm and Lisa and also Dave and Darla both on who are subject matter experts for a few of the recommendations that we currently have on the table. So typically the discussion of this meeting is just for committee members, and occasionally we'll invite subject matter experts on to help us make sure that what we're recommending is really grounded in what would be impactful for Nevadans. And then, so my hope is that we'll be able to talk through those, discuss the rest of them, and then committee members, there'll be kind of a time at the end to brainstorm anything either you've heard today or that you've been workshopping that you want to discuss and put forward. So any questions on that approach? If not, we'll hop into our first current recommendation. All right, so this is a recommendation that was brought forward from our 2024 report. It was submitted by a prior member, Debbie Nadler, and we're carrying it forward into this report. It's related to some of what was shared today from this group. So to create a bill draft request to allocate a 15% set aside of cannabis retail funds to be distributed using a local lead agency's model to reach $2 per capita, a recommended funding goal from the Nevada Tobacco Coalition, Control and Smoke-Free Coalition, and subject matter experts. What I heard you say was slightly different than this, because it wasn't related to cannabis retail, it was related to cannabis wholesale funds. Did I catch that correctly?
Yeah, Chair Johnson, that is correct. So we would amend this language.
So based on the recommendation from the presentation, if we were leaning into the coalition's recommendation, would be to update the word retail here to say wholesale funds, and the $2 per capita is that $6.4 million threshold.
Yeah,
is that correct?
Yeah, so Chair Johnson, I would say my wordsmithing would say cannabis retail tax instead of funds, so that it's more specific on what we're talking about. But I would say wholesale. I mean, cannabis wholesale tax to be distributed using local lead agency models to reach $2 per capita or $6.4 million, correct?
Okay, thank you. Thank you for helping us wordsmith this piece. Does the committee have any discussion on this proposed agenda item? I don't know, Mary, if we're able to workshop live and make some, based on the feedback from our subject matter experts today. So to augment the word retail to wholesale and the word funds to tax. Thank you. And then Malcolm or Lisa, based on your presentation, were there any additional recommendations?
Chair Johnson, yes, I would say I would also strike out the 15%, because if we're saying the $2 per capita, then that might not be equal 15%. Does that make sense? So my recommendation would be, just to make it easier, would be create a bill draft request to set aside cannabis wholesale tax to be distributed using locally agency models, and et cetera, et cetera. So I don't think we need to say 15%, because that might not equal the $2 per capita, because just so you all know, the cannabis tax, whether it's retail or wholesale, is decreasing every year. Less and less people are using cannabis products. So that number is decreasing as well. That's my recommendation.
Thank you for helping with that wordsmithing, Malcolm. I appreciate it. Discussion from the committee on this current proposed recommendation with some of the suggested edits from our subject matter experts on today.
This is Wendy Nelson. I was just thinking, because we're talking about the other tobacco products, and that's under different tax, OTP, other tobacco products. And I was researching, it looks like we get about 30.8 million a year from that. And it's interesting. I think we are getting feedback from our principals and people in the schools that, a lot of the pouches are happening, and it may not be a bad idea to do this with the cigarette tax, but also maybe do a 1% increase on the OTP, because 30% right now. And if you just went up 1%, I think it equals about $1 million, which I don't know if that helps us get anywhere, but it may keep, I think it's shifting. And and as he's saying, like with the, as Malcolm is saying with the marijuana, some of it is going down too, because a lot of people are buying marijuana illegally on the street as well. And that's a factor that we're finding. And so it's how do we tax it properly? And I love the presentation. $2, it's like, what is it, $1.80 right now from what I see? So it's $2, so that's 20 cents. I don't know, Malcolm and Lisa, do you guys have any anticipation of who will push back on this?
Subcommittee member Nelson, through Chair Johnson, I think there are lots of people who are going to push back on a tobacco tax. If you're talking about a tobacco tax increase, I think the casino industries will. I think the tobacco industry will come out very strong against the tobacco tax. So I think the normal players who we would anticipate to be against a product would come out. And even some, Chair Johnson, I want to make this statement very cautiously. Even some people who are on the prevention side might be hesitant about a tax on other tobacco products because they're going to say the keywords of harm reduction, right? Is vaping safer than people smoking combustible cigarettes? And our statement here from the Nevada Tobacco Control and Smoke-Free Coalition is safer does not mean safe. So we think that all products, all tobacco products, other tobacco products and cigars and combustible tobacco products should be taxed at a paritable rate across the board, and no harm reduction incentives for a tax structure when it comes for pricing strategies for tobacco control, if that made any sense at all. Thank you.
Yeah. Thank you for your question, Vice Chair Nelson, and response. Malcolm, I appreciate that. I do just want to focus on, if possible, this specific recommendation just for a moment. Wondering if there's any additional discussion from the committee on this item as amended with our subject matter experts on the line. Malcolm, go ahead.
Sorry, Chair Johnson, I just want to clarify why we keep using the wording local lead agencies model, and you'll see this in this cannabis one, and the next one for tobacco is local lead agencies. If the funding goes to local lead agencies, then we can ensure that the practices that are the money that's being used are on evidence-based best practices when it comes to prevention strategies, whether it's cannabis or tobacco. So sometimes community groups or community organizations might not be operating in data-driven evidence-based practices, and we know that local lead agencies are. So that's why that line is super important for us to make sure that the funding goes to the right organizations or right people. Thank you.
Thank you. So if there's no further discussion, I'm wondering, we get the opportunity to present our proposed recommendations in April. Is the subcommittee comfortable with moving this forward for presentation at the SURG meeting in April as something that we are entertaining for the 2025 report?
Is the process we just yell out? I do. Stacy.
Yeah, you can raise your hand, come off mute,
Sorry.
Go ahead.
Thank you.
Go ahead, Member Lance.
Sorry, yes, I would agree. Putting this forward makes good sense. So thank you.
Great, thank you.
Kyra Morgan, here, I agree.
Okay, great, thank you. All right, and as amended, is that correct? Member Lance and Member Morgan? Okay, I see you nodding your heads on video. Okay, terrific.
Yes, please.
Right. Okay, this will be great. So, so the next step, so as amended, we'll move this one forward to what we are considering to get feedback from the full SURG in April, and then we can bring this back to a vote for any additional edits from the SURG meeting, and then hopefully a vote from our committee as we move it forward. Does that sound amenable to the members? All right,
Yes.
fantastic. Okay, great, thank you. All right, the next one that we have is our Board of Pharmacy one. So this is a current recommendation on the table, and I believe we have 2 subject matter experts joining us from the Board of Pharmacy. So this recommendation requests guidance from the Nevada Board of Pharmacy posted to their website and communicated to pharmacists to clarify regulations pertinent to the distribution of naloxone in hospitals, to permit low barrier naloxone distribution from emergency departments, and permit emergency departments to adopt naloxone specific standard operating procedures for public naloxone distribution, separate from and exempt from the regulatory framework surrounding hospital formulary medications used in patient care. It's a little wordy at the moment, so open to wordsmithing, but I would love, I believe both Darla Zarley and Dave Weiss are on. They've presented to our board before and are generously joining us today. So I don't know if you have any initial input or if the committee has any questions about this particular item. Mr. Weiss, I see you off mute. Feel free and share your thoughts.
Yeah, this is Dave Weiss. I'm the executive director. I'll speak for Darla and I both. You guys are the policymakers, the recommenders. We're here to support you. Anything that you give us, we will do if it's within the law, which I think it will be. Certainly can answer any questions, but appreciate the thoughtfulness that you've done till now and the work that the committee's doing. And we'll try to work with you to reach the goals that you want.
Fantastic, thank you. Sorry, there's an annotate button next to my unmute button and I keep trying to draw on the screen, so apologies to everyone on the committee today. Any questions from members or thoughts on this recommendation as currently submitted?
Is there a reason that we'd need to keep posted to their website language in that part? I just didn't know.
Thank you for the question, Vice Chair Nelson. So what I've heard from community members, and this is where the genesis of this was, is that folks wanted something that they could point to as kind of ongoing guidance. And in reviewing the Board of Pharmacy's website, which is very comprehensive and a great resource in case you've never looked at it before, there does seem to be a few locations like an FAQ page and other places that might be a natural fit for a long-term reference for this particular ask. So
I can make a comment on it too. Yeah.
Please, yeah, go ahead, Dave.
For us, we're a bigger board. We have 45,000 licensees through various countries and throughout the United States. And there's a lot of criticism to all the things we do. So I think the more detailed, because we can put something on our website, everybody wants something on our website, right? So the more detailed that you are, it helps us be able to find our lane and say, this is why we're doing it. I prefer, don't leave it to us because there could be outside sources. So I think the more this is detailed, I understand it. But I think if you want to get it done, the more details you provide to us is better for us. So not that we don't make great decisions, but I think Kyra will concur that things can get changed a little bit. And so it's best when it's spelled out for us.
Thank you. That's awesome.
Thank you. Yeah, no, thank you. That's a great answer to that question. In submitting this recommendation, I did include quite a bit of language in the justification and some examples of what I think would be really helpful for this website posting. Happy to make sure that's available to this committee to review. It's based on the National Bridge Guidance, who worked in the state of California to increase distribution of naloxone at hospitals and urgent cares throughout the state. So, and we're very successful at increasing the naloxone access and reducing overdose deaths. Ms. Morgan.
I just want to make sure I'm understanding the recommendation. So the recommendation itself doesn't have to do with the regulations related to the distribution of naloxone in hospitals. It's really just about communicating guidance related to that. Okay.
That's correct. So when we received a presentation from Darla and Dave previously, and there are some hospitals in the state who are doing naloxone distribution in this way. One challenge that we've run into is hesitation in communicating about this, is some hesitation about not quite understanding what the position of the Board of Pharmacy is. And I will say they've been fantastic. We say, just call them. They're delightful. They will help you. One strategy to help fill that gap has been to have guidance about how hospitals could do this that's easily accessible, so that interested parties could move this forward. Does that make sense?
Yeah, it does. Thank you.
Great. Any other questions or discussions from the subcommittee? Any other input from our subject matter experts?
No, we're here to support you.
Thank you. Is the committee interested in including this on the April SURG agenda for discussion or presentation, sorry, as one of the proposed recommendations from prevention?
I would want that to move forward. So I think that's a great idea.
Okay. All right. Any further discussion, or those who want to continue to workshop a little bit more prior to moving it for consideration?
This is Kyra again. I would just second Wendy to move it forward.
Okay, thank you. All right, we will move this to the April agenda item. All right. This is our another one that was elevated from 2024. It's related to increasing increasing primary prevention funding. So this would support, and I think this group could identify a partner or agency, or perhaps when our legislative member joins the subcommittee later, could help us in identifying who might be the best partner or agency. So to help introduce a bill draft request in the 2027 legislative session that would double the annual state investment in primary prevention via general fund dollar line item committed to BPHWP's prevention programming for people aged 0 to 24. Money should be directed using local lead agencies that prioritize evidence-based programming. And then there's an example given here, which was provided from the previous iteration of if the current level of investment was 1.6 million, this would be raised to 3.2 million for the next biennium. The funding should not be at the expense of existing programming and should be the state of Nevada's contribution efforts to prevention efforts. We workshopped this in our November meeting with some input from Stephanie Cook as a subject matter expert during her presentation. Thoughts from the committee on this current recommendation. Do you, oh, sorry, go ahead, Member Shanae, and then Member Nelson.
Thank you, Chair Johnson. Noel Shanae here. My recommendation, and I honestly do not putting it forward, I don't have a solid answer, but I do feel that if there's any way for us to get more specific as to how the state should fund this, and not just so broad as out of the general funds, I think that would give us something more successful and tangible. As we hear often, the state's general fund is already maxed. And so providing some guidance in that direction, I think might be beneficial for this recommendation.
Thank you for
And-
that suggestion. Member Nelson, go
Sorry.
ahead.
Sorry, I second what she was going to say. It really needs to be defined a bit more. And with prevention, I did read through the notes from Stephanie, and I know that there is a lot of effort towards treatment right now, and prevention is really important. So I didn't know, I had a question with I'm sure we're having a shortage with how things are going with Las Vegas income. What's our likelihood and pushback on this that you guys have input on?
Great question, Member Nelson. Any thoughts from the committee on challenges or opposition in this particular item?
This is Kyra. Just agree with the comments that have been made. Just the idea that the expense should not, that the funding should not be at the expense of existing programming. Kind of will have to be right at the expense of something, because I don't think we're making more money. So just agree with the previous comments.
Yeah, thank you for that. Malcolm, did you want to weigh in on this? I know that you had some other funding
I do,
mechanisms.
And I just wanted to throw this out to the subcommittee and you all to mull over. But one of our recommendations for tobacco was to increase the price of tobacco products. If we increase the price of tobacco products by $2, we would generate over $70 million for the general fund. So my thought is, if Committee Member Shanae was mentioning where is this money coming from, it could get more specific, and it could say through an increase of tobacco tax money allocated for primary prevention. So that way it's a new funding stream that's coming into the state of Nevada, not taken away from existing programs, and it has a lot of money. It'd be $70 million that Nevada would take in for a tobacco tax. Just an idea, just wanted to share. Thank you, Chair Johnson.
Thank you for sharing your thoughts as a subject matter expert on today, and someone who presented us with a lot of options for funding recommendations. Lisa, did you want to add to that as a subject matter expert today?
Thank you very much, Chair Johnson. Yes, some states have dedicated prevention dollars into a trust fund so that it keeps earning money as things go on, as life goes on, so that it's not continually going to a funding source begging, but the money itself is making money. So I just wanted to suggest that as an option. Thank you.
Thank you for that suggestion. Grateful to have such diverse subject matter experts on today and helping us think through some of these recommendations. Thoughts from Malcolm or Lisa's comments on amendments to this current recommendation?
Noelle Shanae, I really appreciate that feedback, and I like Malcolm's recommendation, and it also got me to thinking about what other substances, legal substances there are out there that are taxed, and where does that funding go? In particular, alcohol would be another substance. So there are some other funding streams. We're probably a little bit late in the game to look at what the alcohol tax really truly looks like, and if there's opportunity to increase there or reallocate. But I certainly respect and appreciate what has been shared. And I like that it is not tied to federal funding. As we hear often, the state in some ways is pushing prevention towards leaning more heavily on federal funding, in a lot of ways, Medicaid funding. But we also hear that Medicaid funding is getting cut. So it's kind of almost like a doom loop in some ways. So thinking outside the box and looking at these other funding sources, I do really appreciate. So that is my feedback. Thank you.
Thank you. So I really appreciate the discussion and thoughts shared here today. It sounds like perhaps we want to continue to refine this one so we can mention it as something that we're continuing to workshop at the April meeting. For the SURG, thoughts from the subcommittee on that recommendation of the recommendation?
I think we really need to dig into this and have some really robust discussion so that we can make it work. I think that would be really great.
Fantastic. Is there a subcommittee member who would be interested in doing a little bit more research on this one and bringing it back to our May meeting with some additional details?
I'd be happy to be a part of that if anybody else wants to join me.
Thanks. Thank you, Member Vice Chair Nelson. We will I know that our SEI colleagues have a lot of background on this, so happy to share what we've looked at so far. And it does sound like you were able to review Ms. Cook's presentation in additional detail. So I'm happy to share where we've been so far, and would love to hear your evolution of this one. Thank you so much. All right, let's move to the next one. You guys are troopers today for our long March meeting in lieu of a February meeting. This is a new recommendation from Member Lance, so I'm going to turn the floor over to her to talk about this one.
Yes, Stacy Lance for the record. Thank you so much, Chair Johnson. I wanted to kind of just put this out there for further discussion. It's, I would say, a little underdeveloped, and it's my first recommendation through the committee. So I'm actually really excited for additional feedback and maybe recommendations for a subject matter expert or a few on this. So the gist is basically creating a coordinated county and statewide referral hub that can help quickly get people into the services that they need, bringing together the committees and coalitions that can share best practice standards and help reduce some of the silos. Exploring trauma-informed approaches, such as the community health workers or peer recovery specialists in the clinical settings like an ER, OB's office, other clinical settings. And this would be to provide warm handoffs, start referrals, and support the plans of safe care, which ultimately the hope being that there's a reduction in prenatal exposure, improving birth outcomes, and preventing child welfare involvement. So I sort of started with reaching out to people within Washoe County Human Services Agency, because we do have two separate specialty tracks. One of them is called Safe Babies, and the other one is START, which stands for Sobriety Treatment and Recovery Team. I also reached out to a couple people at Renown and got connected with Rebecca Gonzalez of, she's at Northern Nevada Public Health, and got a whole bunch of other names of people that I have not had an opportunity to connect with. So I'm just open for feedback, further discussion, and working through the process. So thank you. Any questions?
Yeah, Member Lance, thank you so much, and congratulations on your first of hopefully many recommendations for this subcommittee. I'm interested from this group if you have any feedback or thoughts, directionality on what's proposed here. My first thought, oh, sorry, go ahead, Wendy.
You're good. I think on this, the first thing that comes to mind is that rural transformation grant, and this would be great language for anybody to include in their application. It's just that's I see the need. So
Absolutely.
sorry, immediately my mind went there.
I was thinking about the role of the response subcommittee and wondering if this is something that maybe crosses both like a shared recommendation in thinking about how that group has looked to fill gaps. I read this, especially that referral kind of hub place for prevention being like a key kind of hub and spoke strategy, and then those other community connections maybe being part of a joint recommendation with response. I don't know what your thoughts are on that, Stacy.
Yeah, I think that makes really great sense. I was thinking of it from the prevention of exposure for infants and then further pregnancies, and then also preventing them from future trauma and all of those things, from removals and child welfare involvement. But I definitely agree. And as we've talked through the other recommendations, I was actually thinking kind of the same thing. Is there a process for that? How does that information transfer? Like maybe I just reach out to the chair of that committee. I would be happy to do that if you think it's a good idea.
Yeah, I mean, lucky for us, I think the chair of that committee, I don't know if Dr. Kearns is available, but I think she might be on today's call, and just if she's able to come off mute and share any thoughts. Not to put you on the spot, Terry, sorry.
No, that's fine. Terry Kearns for the record. Yeah, this looks like one. What we could do is take this to our next response subcommittee meeting and present it to the members and get their input. But I don't see any reason why they wouldn't welcome partnering on this one.
Thank you. Yeah, if I can just get the date of that and how that process works, I would really appreciate it. Thank you so much.
Certainly, no problem. I happen to have an in and can get you on the invite.
Perfect.
Thank you. Member Shanae, go ahead.
Yes, thank you. Noel Shanae, so this is a wonderful idea, and I think there are many across rural Nevada who are working on similar, from what we've heard. Prior SURG member Schoen has actually done some work within this space as well, and may be a great subject matter expert on that. And I know is also currently working on some work in the rurals around living room models, which this seems to really tie in quite closely with. And I believe Dr. Kearns is also familiar with that. And as you shared, it really does cover the gamut from that prevention to response and some treatment in there. So it is this beautiful hub model, and I see lots of possibilities, and many people who buy into this vision and are looking at it under that rural health transformation program that Ms. Nelson spoke to. So lots of possibilities here. Very good.
Thank you. Go ahead, Dr. Kearns.
Yeah, I just had a question, and I've sat in and listened to some of the meetings on the Rural Health Transformation Program, and I just wonder for timeliness. Wendy, I like your idea about pushing this and putting it as justification or program for some of the communities to look at. What are we looking at for a timeline? And if this comes under a recommendation for our August 1st, is that too late?
Great question. Is anybody connected with the Rural Health Transformation Grant and has thoughts on that?
Noelle Shanae. I am a member of that steering committee. If this goes forward for a recommendation to SURG in August, for year one of the rural health transformation, most funding should have been allocated by August or allocated by the end of August. So this would come too late for allocation of that funding. That funding is proposed to, or will all be allocated through requests for applications and requests for proposals. But they are all due by the end of August. So it may come too late for most of those. Many of them are due in the April-May timeline. So depending on how this fits in.
Thank you for that guidance. With that in mind and wanting to elevate this, hopefully there's opportunity at the next response subcommittee meeting. And then if there are no additional edits to this, hopefully we can share it at the April SURG meeting so that it's on the record, and an opportunity for hopefully someone to pick this up as a project to help close some gaps. So great, thank you, great discussion. Thoughts from this committee on including this as a possible joint recommendation with response, pending any of their edits to this item.
I like it. And I think it'll be great to share some of these thoughts out with people that are doing their application. It's a lot of gaps that are happening out in our areas. So, yeah.
Thank you, Ms. Nelson. All right, wonderful. And thank you, Ms. Lance, for putting this thoughtful recommendation together.
Thank you, guys. Thank you for the feedback.
All right, Mary. I wanted to add one more before I open the floor for discussion of any other recommendations to come forward from today or thoughts. I submitted, this is a new recommendation, but it is adapted from a 2024 recommendation around naloxone saturation in Nevada. So it's my understanding that, so the current recommendation as written is for Nevada, it says DHHS. I will likely need to change that to the Bureau of Public, no, I'm going to get it wrong, so I'm not even going to say it. The Bureau language that we have in the prior recommendation, apologies to, and no disrespect to anyone on the call. So to develop and share a biannual naloxone saturation and distribution plan for overdose reversal medication. DHHS should utilize opioid settlement dollars to designate a baseline level of identification and overdose reversal medication for the next 10 years in Nevada, which should be based on this saturation plan, to create a supply of stable, sustainable overdose reversal medication throughout the state. This distribution should ensure reach and saturation based on overdose burden and ensure it's staffed appropriately to allow for timely turnaround and naloxone access. In the previous advisory committee for Resilient Nevada, there was some discussion around naloxone distribution, and in my role at the Southern Nevada Health District, have heard from some community members outside of Clark County who have had just some challenges with some gaps in naloxone access in other parts of the state. So it prompted me to think that maybe there was opportunity to revisit this discussion as a subcommittee and think through if this recommendation should continue to move forward if it needed to evolve, but to really understand sort of what the gaps and opportunities are around naloxone access. Any thoughts from the committee? Go ahead.
Sorry, Jessica, it's Wendy Nelson. Yeah, this has been something where we have had issues. As you know, out in Pershing County, which we do service, we have Burning Man. And so we're always on a on a challenge trying to get enough naloxone for that event as well. And so, yeah, this would be great to keep, developing this a little bit more because we do have some gaps.
Thank you for that discussion. In thinking through this, I do think there's opportunity to think about the settlement funding as a baseline, and then having the opportunity to use grant dollars as they're available to increase or identify, where in the state this might be a gap. However, thinking about what is needed from a community level intervention for naloxone access, I just think is going to be really important long term. Noelle, I saw you come off mute. Would you like to?
Yes. Please, Noelle Schnee. So for clarification for me, as you're discussing distribution here, as well as, based off of identification, overdose reversal, or baseline level of that, are you looking at specifically what comes to mind is like a map or a supply chain as to where people can access naloxone, be it even out of a box on a street corner, and if that's available, or are you looking at just kind of like community level saturation in general? Certainly I see some barriers even figuring out where you can access naloxone, as well as a steady supply of a naloxone that can be reasonably distributed, i.e. like not expired, etc. And where do people find that, especially those who do not have access to some of these community-based services due to lack of transportation, remoteness, etc. So, a little clarification for me as I'm trying to envision what this could look like, because certainly I think we need to make sure that it is available, and how are we doing that?
Great question. I hadn't thought through how in terms of identification here. I would be interested if the committee wants to add any recommendations for how. Wanted to really leave this up to just given the diversity of our state, I imagine that there's a lot of different opportunities in places like Clark County or Washoe County than in, Ely and Pershing County and other locations in Nevada, and what might make sense for local communities. Really, my goal in thinking through this recommendation was to just sort of ensure a saturation plan and availability and a plan for reach based on overdose burden across the state, and then letting sort of communities identify within the scope of the law where that naloxone access might, how that might need to look and where that might need to be. But open to your thoughts on how to refine this.
Again, I had a little something I was going to add on here. With the naloxone, some of the issue is some of the funding on the backside for the people that are actually distributing it is that they're trying to get, accurate information as to who's using it, and they've tried QR codes and things. A lot of times, the folks that are needing naloxone aren't wanting to fill out their name with the QR code and fill out some of that. Sometimes we're trying to put it in ourselves. And so some of the tracking, you know what I mean? I don't know, we want to get into the weeds on that, but just so you know, there's some issues with that. So I don't know if that needs to be discussed at some point, but I'm putting it out.
Thank you for that contribution, Ms. Nelson. So you're just to summarize, it sounds like something in here that could include the words like low barrier or low, I don't know, data tracking. So from what I'm privy to, and maybe others on this call can say more about that, is that because overdose education and naloxone distribution is a best practice, it's often not recommended to collect data about the use, to have it as an optional item if people are able to report use and utilization. But I'd be happy to look more into that and see if that's something we can incorporate if the committee is in favor of that. Ms. Shanae, were you going to add something else?
I'm looking at this recommendation and really wanting to for me, I really do like this next recommendation, and I know there is you know, naloxone available, but making sure that it is, you know, accessible. So if there is some opportunity to, you know, add in here, ensuring accessibility, especially within our rural and frontier communities, and creating some new avenues for accessibility. I think from my experience as a first responder that there's much hesitation about what that even looks like to be able to distribute, at least in the rurals, naloxone on scene if there's any suspicion of, you know, possible need when you're on scene, or with a family or a suspected overdose, whatnot. Maybe there is no overdose, there's just some indicators while you're there for another medical reason, but it may be best practice based off of the supply of opioids that are even available due to prescriptions, etc. So wondering if there's opportunity just to make it a little bit more specific and tangible in our ask here, you know, if there's a and I'm kind of rolling things around in my head as I'm speaking, so I apologize for not being really eloquent, but I'm a ponderer and a talker, so apologize.
No, thank you for that contribution. It sounds like this committee is recommending a little bit more engagement on this item. So adding something about low barrier access, adding about accessibility. I think we have covered availability in here, so ensuring accessibility, and then some type of recommendation around data collection. Those seem to be some of, if I capture that, some of the barriers that folks are experiencing around access.
Yes.
Yes, I would agree. I do think, you know, that really does address some of the barriers, you know, a map of where you can find it, you know, some things of that nature would be beautiful.
Okay. And I'm aware that there are a few different efforts of mapping that have happened over the years, or maybe more locally based. So some thoughts on sort of what accessibility would look like. Maybe we can include something like a map or an easy click button for folks to access that. Got it. Thank you for the discussion here. Thoughts from this committee on including this in April as something we're still workshopping? Any hesitation about doing that?
I think we need to move it forward if we can.
All right, thank you. Apologies if my room is getting dark. The sun is setting here in Washington, D.C. I know it's a late afternoon for you all as well, so I appreciate the fortitude of focus in our meeting today. All right, Mary, we can move to the next slide. So I don't know if based on today's discussion, I wanted to just make room for any additional recommendations that folks wanted to work through on the fly. Anything that, oh, go ahead, Ms. Shanae.
A lot of what I was coming to the table here with, we've touched on elements of it, right? That sustainability of funding, and how do we create that more specifically? And then as I mentioned in this last one, what does that EMS piece look like, especially within rural communities, around both naloxone distribution as well as like your doTERRA or your other disposal systems, and including those EMS or maybe those rural providers, those rural home health providers, your hospice providers, et cetera, who often don't know of these options for disposals of opioids from my finding within my work, nor do they have any comfort in distribution. Much like the pharmacy board recommendation, there's a strong desire for some standardizations of SOPs and ensuring that there's following best practices, as well as not jeopardizing any agency by going outside of a scope of work or a scope of practice. I'm sorry. I was just looking at a scope of work a little bit earlier. So I don't know if there's any appetite for such a recommendation from this committee on that kind of home health EMS side of it for some distributions of naloxone and medication disposal systems to help just remove some of that opioid medication, one from our rural communities for safe disposal, and put in their hands naloxone that can be utilized if needed, given the circumstance, thinking of the lack of pharmacies, the lack of hospitals for access, et cetera, and conversations. So open to thoughts on that.
Thank you, Ms. Shanae. So to clarify, are you interested in something that is more like what I would consider a leave behind initiative? So ability for those groups to leave behind naloxone in the community, or for them to deploy naloxone if they suspect an overdose?
It would be more of a leave behind initiative. So, and creating some standards behind a leave behind initiative that creates a sense of security and brings awareness. Thank you.
That sounds great. Yeah, no, definitely. This committee in previous years had looked at the STOP Act out of Maryland that specifically, I don't want to use the word mandated loosely, but I believe it might be mandated first responders, which was pretty broadly defined, and leaving naloxone if there was a suspected opioid overdose. I don't want to misquote all the details of that particular act, but that might be some language to start with in terms of groups that could be impacted, or groups that could be impactful in the opportunity to connect with folks, and maybe based on the geography of our state, there are additional groups that might be relevant for, but one recommendation might be to start with that language from Maryland. And I believe Mary could probably help us pull up or share with you, I believe it was either our 2023 or 2024 recommendations. We don't have to pull them up right now, Mary, but that include that as an idea.
Thank you for that direction, Chair. I think that's great, and I will take a look at that as well. And yeah, lots of possibilities.
Thank you. Dr. Kearns, is there something you wanted to add?
Yes, thank you, Terry Kearns, for the record. I was just going to say, I do remember a similar recommendation previously from the SURG, very similar to this. And also, spoiler alert, but the response subcommittee is looking at a kind of naloxone, free naloxone and opioid, not just opioid, but all drug disposal kits. So we have a recommendation. So it sounds like this might be another chance to collaborate.
Fantastic news. A wonderful opportunity. Clearly, we have subcommittees, but this work is broadly focused and cross-cutting. So I appreciate the opportunity to engage there. Ms. O'Bannon, go ahead.
Thank you. Okay, so this is Rosa O'Bannon for the record. I do have a question, kind of like a follow-up with Malcolm's presentation. Now, thinking about the cannabis taxes, as it's already coming into the education fund. Now, and this is just a question, again, my first meeting. So, would there be an opportunity to make a recommendation that maybe 1% of that cannabis tax money be allocated for prevention within the school system, specifically at the middle school? Like we could focus on that middle school group, maybe some programming around some evidence-based programs, and using at least that 1% of that the what was it, the retail, I believe it was the retail that is already going into education. Would that be even something that we can look into, looking at the increase in cannabis use among youth? So now we're reallocating specifically at least that 1%. And I did some research. I just kind of looked it up, and there's about anywhere between 100 million to, I guess it's dropped, but there's that opportunity would be already internally coming to the school districts, but really focusing on allocating that 1% for prevention. Just a thought.
Thank you for your question, Member O'Bannon. Malcolm or Lisa, would you like to answer that question?
Please go ahead, Malcolm.
Lisa. No, go ahead, Lisa.
Okay. Thank you for that. Thank you, Chairman, and thank you, Committee Member O'Bannon. In my experience in being in the schools, so many dedicated professionals are working so hard every day just to keep the school together. I would hesitate to add another demand upon them. I mean, I think the health districts exist for prevention in a lot of our areas, at least in the chronic disease realm, and so that would be my immediate reaction to that is we're standing by ready to implement. So thank
you. Thank you. Malcolm, did you have anything you wanted to add to
real quick, Chair Johnson, real quick, Chair Johnson, just wanted to second what Lisa said, but Subcommittee Member O'Bannon, I think this is a fantastic suggestion. I think it's great. It's just that if we're practicing CDC's best practices on prevention, I think that is tackling the 1% carve out for the school districts is tackling just one component of it. We still have to incorporate the evaluation, the mass reach, and all these other components to a comprehensive program. So I think we support it with other elements as part of that recommendation as well.
Thank you. Ms. O'Bannon, any additional questions?
No, thank you. Thank you for that clarification.
Wonderful. All right. I am really grateful for the robust discussion and for our subject matter experts who have given us many hours of their afternoon today, weighing in on making these workshops more actionable and clearer for our state. So thank you very much. And just an encouragement to the group and a huge thank you to Ms. Lance for her recommendation. If you think of any additional recommendations from the presentation today or other gaps that you're seeing across the state that you'd like to bring forward, please feel free to do so. Mr. Allo.
Chair Johnson, one quick question. I had a request from Subcommittee Member Chelsea Cheatham, about the who gets funded using the Master Settlement Agreements. How would you like me to deliver that? Is it through you or through Mary and Kim?
Thank you very much for following up on Member Cheatham's question. Mary or Kim would be happy to receive that information and can get it out to our subcommittee. Thank you.
Thank you, Chair John.
All right. Great discussion today and great progress subcommittee on many great items here for our report. With that, I'm going to close agenda item number 6 and move to agenda item number 7. So this is an opportunity for us to discuss topics of interest from the subcommittee. On the next slide, we had a very robust discussion in November about both potential recommendations and ideas that this committee had for new topics for us to focus on. Some of this we've had organically under agenda item number 6 as we're thinking through some of the many dimensions of our work here together. So the 2 topics on the screen, integrating prevention strategies in crisis situations and strengthening the prevention component within emergency medical services, especially in rural communities, were discussed. I am interested in any additional discussion from this committee on areas or topics of interest. Ms. Morgan.
Hey, I'm sorry to interrupt, but I think I need to drop from the call. But am I going to mess up quorum? Because if so, I can call in on my drive. I have a commitment.
Thank you.
Are you guys good?
Consideration. Let me, Mary, can you confirm if Ms. Morgan drops off, will we lose quorum?
We will not lose quorum.
Okay, perfect. Thank you, guys. Sorry to interrupt.
Thank you. No problem. They did the exact right thing as we get more comfortable with that notification. Just wanted to generate an item here to discuss any topics from committee members that are of interest related to the prevention subcommittee. We have guidance from the full scope of the SURG related to AB 374 about paragraphs A through Q related to kind of the prevention. So primary, secondary, tertiary, including harm reduction efforts. So would entertain if anybody wants to share topics or areas, things you're thinking about related to prevention.
Noelle, Shanae, and for me, these are still topics of interest. I would share that I do see this integrating prevention strategies in crisis situations really aligning with the suggested recommendation earlier with that central hub and spoke model. So I kind of see us going down that pathway in some ways already just out of our discussion today. And then while it sounds like there is some crossover with the Leave Behind initiative and I believe you said it was the response group, Dr. Kearns. But I think there's some possibilities within that emergency medical services component, as often they are the providers in rural Nevada and frontier Nevada. So
thank you. Well said. I appreciate that. It sounds like these are still topics of interest for this group. Other members, any topics or gaps that you're seeing in your work or that have been brought to your attention as a member of this of the SURG that you want to discuss? Seeing no one immediately jump off of mute, that's okay. If you have topics of interest or are considering a recommendation, have thoughts on someone who could provide some subject matter expertise, whether that be yourself or another group in the state, Mary and Kim are here for you to help us with that. So just wanted to continue to encourage you on that front. Just from today, I think having Dave and Darla and Malcolm and Lisa here to help guide us in really making sure what we have is actionable and addressing the gaps in the community as folks see them, can be a really beneficial strategy, I think, in terms of having actionable items that help us to fill gaps. So a huge thank you to our subject matter experts who were able to join us today on that front. If there's any additional recommendations that come up between now and our next meeting, I know Mary is excited and ready to receive them for discussion. Noelle, did you have another item that you wanted to discuss?
I did. Thank you, Chair. Another topic of interest for me is with this prevention, and we have talked at great length today about sustainability and increases in funding models. And as I mentioned earlier, there is some drive from DHHS and DPPH to look at Medicaid for some funding stability within prevention. But there is a lack of understanding, at least on my part, as to what that looks like. I don't see, we talk a lot about universal prevention. I know you mentioned the AB 374 with the primary prevention, secondary and tertiary. And within Medicaid funding, and I am absolutely no expert or CMS, there is, to my understanding, some reimbursement possibilities around, some secondary and tertiary, especially within like treatment type settings. But what does that look like in terms of primary prevention, if that is an option or an opportunity for some sustainability around prevention? And it could tie into this emergency medical services piece. Is there opportunity for them to bill for prevention, for billing for leaving that naloxone or leaving a Deterra in that leave behind policy to encourage that practice? Is there opportunity for ensuring that through primary prevention efforts and reducing population substance use onset and addictions at a later age, that we're reducing that burden on CMS later on, and that we can create some funding within Medicaid. So it's a topic of interest for me at the moment, because it's something I'm not understanding, and it is a direction that we are kind of, when I work in the prevention field, it's a direction that the state of Nevada has shared that we should be looking without additional guidance there. And so are there recommendations or ways that we can build that into a model for prevention?
Thank you for sharing what you're seeing in the community and kind of what those thoughts are and where some of those gaps might be. Sounds like maybe presentation, maybe, Ms. Shanae, that you could connect us up with sort of who you've heard some of these discussions about, so we all can learn about, make me definitely smarter on this topic and how to piece these together. I'm wondering, we have the coalition representatives on this committee as well. So Ms. Nelson and Ms. Cheatham. I know Ms. Cheatham wears lots of hats in Nevada too, as many of us do. Any thoughts on what Ms. Shanae shared here? Is this something you're seeing as well? And would there be opportunity, in your opinion, to have this a presentation like this for our committee?
I can speak to that. Yeah, there is a push to see about having us bill Medicaid, and they're kind of going in this direction where you can utilize peer support specialists because they had an increase in billing, but we don't have the ability right now to do that because we're, prevention. And then for my coalition, we're an action agency as well, but again, that's not treatment. And so we don't do that yet. I know there is a push to go in that direction. I spoke with people, I think it was Silver Summit, and they were saying that is the direction that they're pushing towards. And so we have had that presented to us, and we're trying to navigate that and figure out how we can do that. It's not really clear yet. They said that possibly maybe Silver Summit would have some kind of classes for us. And I actually emailed today and said, by all means, I want to learn anything I can to make sure that I am abreast of how this can work. Stigma is being addressed as a big issue. In prevention, that's really not our biggest issue. We're dealing a lot with the youth. We have a lot of youth teams. And so they haven't gotten to that part where stigma is in place. But of course, on the other side of it, we're dealing on the action agency side, and we do see some stigma that way. So, we're kind of in this weird middle ground. We're trying to navigate it. We want to be at the forefront of it. I know Noelle and Chelsea, I'm sure they're all speaking that same way. We always want to be doing what we need to be doing to be getting the job done. But yeah, there is a lot of discussion, and maybe how to navigate that a little bit better is something we can keep speaking to, because we are literally just trying to figure it out right now. Prevention, it looks like it's shifting a lot just because of, I think, funding streams and things like that. So that's my long-winded explanation.
No, thank you. Thank you for sharing those thoughts, and also just kind of echoing, I think what I heard here is there's a shift in this direction, maybe without a lot. It'd be helpful for us to understand a little bit more about what that might mean for opportunities of focus in prevention, or where the opportunities to work more closely with Medicaid are, and then what are the gaps that still exist in that model. Chelsea, I think I saw you hop off mute. Is there anything you want to add to what Ms. Nelson and Ms. Shanae have shared?
No, I didn't really want to add anything else. I second what both of them had said. We're also working currently with peer recovery support specialists and in looking at the possibility of billing for some of their time, but we just don't know what that's going to look like, especially with our peer recovery support specialists serving in also wearing multiple hats and having different things that they're doing and not only seeing clients. We just don't know about the potential of how much they're going to even be able to bill. So it would be nice for us to maybe have some more conversations around this, have some of the folks who are planning what this might look like come to speak with the group so that we can get a better idea of what to expect in the future.
Well, thank you all for this discussion. If you have, sometimes people are hesitant in the main meeting to share names. So if you could do me a favor and follow up with one of the SEI team members, either Mary or Kim, with some recommended speakers, I think that would be really helpful to see if one, we can understand this a little more, two, if it's connected to any kind of recommendation or helps inform other recommendations that we're considering and have on the table, I think that would be really beneficial. Thank you.
Thank you, Chair. And I do really think this discussion could provide lots of opportunity for future recommendations and guidance just to better support prevention. So appreciate that.
Yeah, thank you for elevating it, Ms. Shanae. I really appreciate that as well. Other topics of interest or discussion? All right, seeing no one immediately hop off of mute, I want to thank you again for the robust discussion so far today. And as we discussed at the outset of this meeting, for this year's report, we are on a little bit of a timeline crunch. So if you are thinking about recommendations that you'd like to see included in the report that comes out in August, there's a little bit more urgency related to them. If you are interested in a recommendation but it still needs more time to marinate, that is okay too. It'd be great to get it on the books for discussion, and maybe it's entertained in our following year's report as we have a chance to workshop it. If you need any kind of reference about what the scope of the prevention subcommittee is, I know Mary would be happy to send that over to you. I won't read all of the details given the length of this meeting and the tenacity of this group here, but it's very well spelled out in our meeting notes and across the SURG. So if you're like, wait, remind me again what the scope is. So happy to reshare those with you all as well. All right, let's close agenda item number 7 and move to agenda item number 8, which is our second period of public comment. Mary, can I turn it over to you to ensure that we're in compliance with open meeting law?
Of course, Mary O'Leary for the record. So as a reminder, public comment will be received via Zoom by raising your hand or muting yourself when asked for public comment. Public comment should be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken, per NRS 241-021. If you are dialing in from a telephone, please dial 253-205-0468. When prompted, enter the meeting ID 813-0733-6896. And then please press *6 so that the host can prompt you to unmute. Finally, members of the public are requested to refrain from commenting outside the designated public comment periods unless specifically called upon by the chair.
Thank you, Mary. Do we have anybody for public comment in our second public comment period?
I don't see any hands.
All right. I know sometimes technology can best all of us, so always wait an extra second in case that's okay. All right, seeing none, I'm going to go ahead and close the second period of public comment and move on to agenda item number 9, which is adjournment. I wanted to express my undying gratitude to my committee members for staying on for an extra long March meeting today. I really appreciate it. And to our fabulous subject matter experts who have graciously given us their time and energy and thoughts today on our recommendations. I look forward to our continued work together, and I will see you at the next meeting. Thank you, everybody.